Okay, so yes, my name is Johan Sonin. I live in the disunited states, particularly in Boston, where I pretend to run a healthcare design studio, and I teach at an academic institution in Cambridge, Massachusetts. Because we're talking about healthcare, you probably want to know, or we should know, what's driving our business or what's driving us. Not that I have any money, but I put it in a blind trust so that I don't get injected into the business side of what I'm designing. And all of my genome, all of my health records, everything has been open source. So you can download my genome, my DNA from GitHub, planted in a crime scene, go for it. If you have any questions, if you'd like to publicly shame me, feel free to email me or use a Twitter account, and I'll try to get back to you within 2 business hours. Okay. I think this is one of the reasons, one of the many reasons why we get into the healthcare profession. It is rather noble. And yet here over the past, I'd say 3 or 4 decades, it's become much more of a business. And I think we're using this cover, this umbrella of nobility to shield our work, to shield our brains from what really is happening in healthcare. Now, if you take the 1 square mile between the private equity firm called Harvard and the VC venture capital firm named MIT, that landmass occupies 25% of healthcare GDP in the United States. That is enormous. And, part of this is, if you look at it in the global context, that's 1% of global GDP in that 1 square mile of Boston, which is insane. Nature doesn't like that kind of concentration. And for the beginning part of this, I think let's start to follow the money. What's happening with it? Because it's a profits over people mantra here in the United States. And unfortunately, that's bleeding into the rest of the planet. And one example of that is the former chief medical officer for Sloan Kettering Cancer Center in New York, a very good cancer center. And Jose here, what did he do? Well, he ran roughshod over most ethics that should occur in hospital settings by breaking all the rules. Okay, so he's on a boards, he had ownership stakes in the startups coming from therapy startups from the hospital, et cetera, et cetera. But really, he modeled this after another famous clinician, Arthur Sackler. That may mean something to many people with the opioid crisis. But this one startup that came out of Sloan Kettering, Page.ai, it's an interesting concept actually, about diagnosing in advance. This idea was paid for by the public. Here in the United States, just like in the UK, a huge amount of taxpayer dollars go into healthcare. But the thing is, when you walk into the healthcare center, your data is owned by the hospital. And 25 million patient tissue slides were owned by the hospital. And it's not just one clinician working on it. You have hundreds and hundreds of them encoding these 25 million patient tissue slides. And another crazy fact here is that who owns the company? If it's coming out of basically a public institution, well, the executive board, the chairman. It's making the rich richer. It's driving me batty. It gets better, don't worry. Okay, so yes, this has taken 60 years to put together these slides. So again, our taxpayer dollars have been funding this. It's owned again by the hospital. And what's crazy too is this idea of a nonprofit. Great. How do we make more money has been the mantra for now at least 2 decades in nonprofit world, because, we can't make enough just doing our normal thing. Now we have to figure out new ways to make bucks. It's funny, this guy who runs the lab is hiding in plain sight. I always find it interesting when you're a CEO and an intern at the same time. But the more important part here is that the data use agreement that the hospital has keeps patients out of control, the DUA. And that's something that's, I think, a pandemic across the planet at the moment. So what kind of design am I sort of talking about? Well, patients have no ownership rights at all. The hospital owns it all. The IP, the patents are owned by the executives, yet we fund it. This is corporate welfare at its finest. And finally, this is really ethics as situationally optional. So This is happening across the United States, whether it's Mass General Hospital, whether it's electronic healthcare record companies, Walgreens. This just happens over and over and over again. And very recently, this is Moderna, the CMO, Tal Zaks. Moderna, one of the, you may have heard of the thing called a vaccine for COVID. They were one of the main suppliers and builders of this vaccine. Talked to Michael Milken on a podcast. Michael Milken has his own history in the United States in the savings and loans crisis and scandal in the 80s. And what did he say? Well, I want to have more effectiveness with my healthcare work. So that's why I'm going to go into private industry. Well, let's figure out what that really means. Well, since the United States injected $500 billion into Moderna, what has he done? He's taken out every week. He took out $1 million a week from the company coffers starting in March in 2020. So, and then he took out about a total of $108 million during his rest of his tenure at the company and then left. So that's what 1 to 3 logs more effective means, is how can I get more money? And again, this happens everywhere. And so I know this is a little depressing. Dana-Farber is doing this here in Boston, where they got caught by the Boston Globe and a newspaper to say, what the hell is going on here with your ethics? And I'm going to go fast through this because I don't want to bore you too much, because this is very US centric. But the problem is it's bleeding into the rest of the planet, where the trustees of hospitals are saying, no, it's okay. We can have people who are investment nuts on the board and have them have direct access to our science. I find this to be pretty depressing. Okay, let me keep going through here. Yeah, I'm not going to bother you with this because it's just I need more Prozac to deal with this. Okay. This is ridiculous. It's like, yeah, of course, we don't want these hospitals just to become vehicles to make more money. Yeah, no kidding. But the fact that they have to say it is insane. But yet we are all complicit in this. We as global citizens are pushing our data everywhere. Yes, GDPR has some protections there, but actually, I'll show you in a few moments, not enough. And it's feeding all of the startups, the big companies, the governments of the planet. So what are we sloughing everywhere? What kind of data is it? Well, I think health data assumes that it's, this is just about our biology or just about the basics of when we go to do labs and things like that. That's not true. Health data is any information about a person's life that helps me make better decisions. This was actually something we seeded on Wikipedia about 4 or 5 years ago. There wasn't an article on health data 5 years ago. It's crazy. And so this is what we started with. And I think this is how we typically frame what health data is. Very clinical. However, as many of you know, it's much more than that. It's your entire life data, in essence. It's what you do in the weekends. It's where you work. It's your zip code here in the United States, where you live. And we have an open source diagram, the determinantsofhealth.org, that starts to map out all of these things. This is available on GitHub too, or you can download. And I'm just zooming in here on what are all the things that are part of our healthcare and health. And it's funny that very little of it is actually our medical care. And if you want to download this and use it, feel free, it's open source. So health data is a lot more than we think it is, and you don't own it, and you should. Now, GDPR should be looked at as a pretty damn good piece of legislation. It's still busy and has huge holes in it. One of them is in the recital 7. It says something really good. It says, okay, persons should have control of their personal health data, but it doesn't make a lick of noise about owning your health data. So you don't in GDPR, and it gets deeper when you go to 63, recital 63. It says specifically, data subjects have access, not ownership. So why is this important? Well, just because GDPR has some better controls, there are still lots of middlemen that are in between you and your data. So when you go see a clinician, you have an encounter, you have the EHR that has access, the electronic health record that has access to your data, the labs that do it, the pharmacy benefit managers. Banks sometimes have snippets. And there are a load of other companies that sniff and whiff your data. When you use Alexa or your Siri or you name your voice agent of choice, there are typically over 450 to 550 different services that your data goes through as it does the round trip between you and Amazon, the Borg, and back again. So something to consider. There are lots of services at play here. If you're interested in this, we have another open source visualization. You can go to whouses-myhealthdata.com. So I'm positing here is my hope is that this age of healthcare surveillance we've been just living through and still live sort of turns patient data ownership into a net positive. That's my hope. It's not like we've just started talking about this. We happened to talk about it in 2006, but that was still late. We were standing on the shoulders of giants. Many people talked about it for decades. Alex Pentland talked about it at the World Economic Forum about 6 years ago. But really it was the advent of this silicon bricks in our pocket that has gotten this even more prevalent. So we have some people on our side who have been talking about it. Here in the United States, we've got some presidents of healthcare organizations, even our version of NHS, but just not as good, at the Centers for Medicaid and Medicare. Seema Verma, who ran it, said, okay, patients need to own their data. By the way, people also get in trouble. This is Betsy Nabel, who I just mentioned, and Seema Verma. They too get in trouble for what they're doing or what they're not doing in healthcare. And I just want to put this in perspective because I'm sort of dirty too. If we look at this across my own work, I have to understand that there are biases that I have been exposed to where I work as part of the military and healthcare industrial complex of the planet. So, okay, not great, but there is a spectrum of dirtiness, and I hope that I'm doing a little bit better than those embezzling $100 million from taxpayer money. Okay, onwards. There's a very good paper that I recommend reading. It's a 4-pager. You know, someone with an IQ deficiency like me can read this and still get it. And it outlines on George, by the way, JAMA in their infinite wisdom only allows 3 authors. It's really dumb. But it outlines 3 really good points to getting patient data ownership and control. One is that you need common data elements. You need the data that describes you in code to be standardized, to be common across the nation. You have a summary care record in the UK, which again has some common data elements, but you guys are working it. It's been a struggle across UK and US. The second part is you need an encounter data receipt. Well, what happened during this encounter I just had? Whether it's remote, whether it's face-to-face, whether it's online, I don't care how it is, you should get a data receipt or a care plan receipt. What the heck just happened? And the third part is you need a contract between you and the service that allows me, the patient, to control my longitudinal health record, then control that data and give access and control who it goes to. So those are the 3 sort of points that this paper lays out, which I think is very good. So to put this into a sort of a visual context, you have an encounter. I don't care if you're in a cardboard box on the side of the road or at home or wherever it is. And after that, you get this thing on your cell phone. It could be even mailed. There may be an analog version. I don't know. There could be lots of different versions of this, but there's some digital transaction. You need to see what happened. And then there's a little data manager that begins to construct, based on that data that you got out of this, pushes it back into your health record, your longitudinal standard patient record. Then that's where it goes. And then ultimately there's different views on your data depending on who wants to see it, if they have access, you know, if it's your care team, your spouse, your child, whoever it is. And then ultimately there's some data use agreement that sits over this that allows you to control who and how for how long someone sees it or has access to it. So I liken this little patient data manager to Tetris, putting all these things together in a nice little record so that it becomes your digital twin that you can do whatever the hell you want with. That is your record to do what you like with. Now, what are some things that sketch you? Well, one aspect is, can you start to see how complete your record is? If you have this standardized model, you can begin to see, well, how many cobwebs are on it? Is it full or not? Is it complete or not? Because when you walk into a session, clinicians typically, or nurses or remote services, don't know your family history for the most part, unless you're doing it every time by hand or whatever it is. Wouldn't it be great if the clinician or the service could say, well, what's missing? What's here? What can we trust? So just one of many things that you get. By the way, another side note, there's a reason why we use a lot of pictures or how-tos or illustrations, because, hey, there was a paper recently written by lots of overeducated MDs and PhDs. I should be careful of how I say that. And the note basically out of this paper was, hey, drawing pictures helps humans grok things. Great. Okay. But we use a lot of this in our work. One, because it's easy for people to understand, but also that executives and research scientists and policymakers need this kind of graphic storytelling technique as part of their work, as part of their public storytelling, and also products do need this as well. So I think and you've seen, I think, a growth of this, and I had a whole talk about this, I think 2 months ago, that was public, that showcased several illustrators and artists talking about the pandemic through graphic novels, through comics. It's a great technique. And so we use this often in our work. This was, about a year ago, showing, well, what is tracking? How do you actually use testing, treating, and tracing, at least here in the United States? We use this for how do you actually then go and get research money? How do you explain the concept in one picture? And this is another open source project that we have called Care Cards that shows care planning in a single picture. Okay, anyways, back to owning your data. So number 3, when you own your data, you control access. So great, let's just take one part of this and I'll show you an example, an open source service we have right now, and we're actually evolving it over the next 4 months. But this is live on GitHub, so you can actually download it. And we use a graphic novel technique. Hey, look at this. I'm wearing the little blue guy on my shirt. I love it. And it shows very simply consent, or what do we do with your data? And it's slightly animated, each one. And it walks through at a 5th grade level, so that you don't need a lot of health education to use this. And then it reveals, we used Apple's Health Kit as a baseline, just so we weren't creating everything from scratch, to show some basics about your health. It even had like your care plan a little bit. It had a transaction receipt. You could actually press play and listen to what happened in your last encounter. How cool is that? When you get a cancer diagnosis, you think you're paying attention the whole time, you're freaking out. Your brain goes into, like, from 0 to 100, it goes probably to a -1 on the listening scale. So you sadly want to relive it or re-understand what happened. And for the real health nerds, you could actually then slide down and see where on the social determinants of health graph your data lives. You could see how full or where the information was. Again, this is pretty nerdy, but you want different levels of the onion to go through depending on what comfort level you are with your data. Okay, so owning your data gives you health autonomy. Well, what the hell do I mean by that? Here are the ownership rights you get for anything. Your house, your t-shirt, whatever you're wearing, you get to possess it, share it, sell it, and even destroy it. Yeah, you do. That is part of the ownership techniques. Now, here's what we are laying out for the state of Massachusetts for a policy that will get to patient data ownership for all residents of Massachusetts, is that you as a patient co-own or fully own every data point about you. Health data is generated about me with a clinician, with a nurse or doctor, is co-owned by both parties. And that health that I generate, health data that I make, is fully owned by me. And I can do whatever I want with that data. So those are the 4 tenets. Now, there's a fourth one here, is that there are some things required by law. When you have a communicable disease, that needs to be typically reported to an agency at a higher level of the city or the town or the state or the county or wherever you are. And so there's some things in law that you have to report. Other than that, though, you should have full control. By the way, we're seeing the opposite of this happening lots across the United States. And one of them is a company called Truveta, which is an aggregation of many hospitals pooling their patient data together. And this is across Washington state. And it's, I think, 1/3 of all of Puget Sound population has their data in this pool. They weren't allowed to opt out. And so you're seeing sort of the opposite occur here in the United States. It's really sort of depressing because it's almost half of the residents of Washington and Seattle. And who owns this? The hospital. The patients don't. And they sell access to this data to amplify their profits because they're a nonprofit organization that made a then for-profit institution to do this. And that's how they have more income. Great. So it's just saying that, you know, your data is becoming just like Coca-Cola, just like coffee. Well, coffee now is unfortunately disappearing because of climate crisis. So drink it while you can. But it's sort of a commodity. This is really bothering the hell out of me. And they even say it. They say it out loud. Here is a Northeastern University professor saying, yeah, they're taking advantage. We are taking advantage because the data use agreements are putting the control in the hospital, not in the patient. So it's like even out in the public and no one gives a rat's ass. So some other things to consider is maybe we need a new category of IP law here in the States and in the UK where it's like time limited, like copyright, maybe. Maybe there's public ownership of anonymized data. That could be something interesting to consider for national law. And the third parties that aggregate it need some kind of little bots that work on our behalf. Now, there's some good progress here on this. Is where's my medical record? Pretty damn good here in the US. They also do open notes where you can read the notes between you and your clinician. The clinician may have private notes. That's not true anymore. It's excellent. We like it. You can fix your errors, but there's no data ownership. The Federal Trade Commission now has fines for protecting consumers' sensitive data. Okay, that's a start. It's still not a criminal act, you know, the pejorative use of your healthcare data here in the United States. So that's something we need to. Think tank here actually said in their report, their strategy for digital health last year, it takes, you know, it's a big company. Sometimes it's hard for them to have the fortitude to say anything good. Is they actually did something good, and they said, yeah, we need something beyond access and actually have ownership. That's really great to see big companies start to talk about this. If you want to hear more about this, you can look at these 3 references. There are lots more, and I will send this PDF out to everybody after the presentation. Look, any healthcare system that doesn't give you your healthcare data is literally mistreating you. And this is the problem with the last frontier of capitalism, is selling your experiences. It's your mind. Because what are the surveillance capitalists doing? Yeah, whatever we can exploit, we're going to do. No one's going to know. Yeah, it's driving me bananas. So we demand patient ownership rights. If you want to know more about this, you can go to datauseagreement.org. Now, in the last like 6.7 or 6.66 minutes, I'll talk a little bit about open source. This is open source. Here, you can go to GitHub. What is GitHub? For those that don't know, it's a place where you can put code. It can be closed code where it's private for you, but lots of it is open, where the software that you use, the designs you use are open. People can interrogate it. There's a license associated with it, and that the community can then comment on it or give feedback or use it and evolve it. And those are the three tenets of open source. And why are these things that we're all doing in this space open source? Well, the fifth tenet, you can't solve this healthcare problem without asking others and to help out, and you build a community around it. Look, the Declaration of Geneva had nailed this 70 years ago. I'm going to share my data as a clinician, as a patient, for the advancement of the domain. And yet here we have, great, I'm a pharmacy benefit manager. I'm a startup outside of London. Our black box is just going to do beautiful things for your health. Great. Well, maybe in the UK and the EU, you're much closer to this. I think the hope is here we're getting closer. However, when you use a digital service, you don't know how this stuff works. You don't know why it works. Typically, what's the research that's driving it? And so if it's so noble, this world of healthcare, if it's key to our life, maybe you don't have as much choice as we think. We demand healthcare to be open. The internet, or at least the infrastructure of the internet, is open source. It's also a human right by the UN. And maybe a more nerdy look at this is the open source model, open source integration model here of how the internet works, where all the way from the physical layer to a lot of the software layer is open source. TCP/IP, HTTP, these protocols that we're using and the services we're using now for this session there's a lot of open source in the infrastructure of this. You can see it everywhere. It's in our silicon bricks. It's in our computers, everywhere, in our refrigerators if it has a damn chip in it, usually driven by some open source software. And yet the healthcare model of this similar stack diagram is that most of it should be. And yet Eric Topol, who's read The Creative Destruction of Medicine, The Patient Will See You Now, some excellent books, has said, yeah, we have anti-open source in healthcare, and this needs to change. Okay, we have some people on our side, but we're still in the early stages of open source healthcare. Estonia, my home country, is the only one on Spaceship Earth that has one patient data ownership and an entire open source backbone to their health IT. It's called X-Road. And yeah, we're making some inroads across the planet on open source, open EMR, open standard health record, health kit, but we're not there yet. We need a lot more effort here. Now, where is open source healthcare well suited for? Well, infrastructure, common goods, some leading edge things that we're maybe working on in the lab or at universities, but also this thing called a global emergency we're sort of living in the midst of now. And I'm happy to say that it's open source healthcare has been thriving in this space. NIH, the National Institutes of Health, have released tons of data specs for COVID and released it as open source projects. For the first time, I'm getting news feed open source healthcare articles. It's crazy. If you go to GitHub, there are 125,000 repositories that are dealing with COVID. Like a date picker is like 4,000. So like there's good things happening here. You know, in the UK, you've got, and the EU, you've got Linux Foundation working on COVID Green, COVID Aware, all these, and VCI, which is the vaccination credentialing. That's a global effort. Fantastic. By the way, all the things that we do in the studio, sorry, I'm looking at, as you can see it, the studio where I am right now are licensed under open source projects, whether it's our coronavirus or Care at Home or HGraph. All these things that we do inside and make for ourselves are all licensed under open source licenses. It's also good to see big coalitions of big companies come together and say, yeah, we need to do this in a much more open way. It's on their website. Whew, okay, pretty good, pretty damn good. But we're not done. And I think it's actually too late to think about March-in rights for COVID vaccines, that we should have done this when President 45 was in office, to say you have limited rights on the IP, and after that it goes global in 3 years. Too late for that. But part of this is we have to start thinking about policy. You don't have to be a president to think about this, or a prime minister. It was just in, I think Boris was in Estonia yesterday, which is pretty cool. But you have to start to think about, well, what policies do we need to change as designers, as academics, as healthcare wonks in our countries? And here's my list, for instance, for the US. But you also then have to say, well, what parts of this are we attacking? What are we going to start to focus on? So we look very carefully about what kind of projects we're going to do, what things why we're going to tackle it. And so we concentrate. You can't do everything well. Even this is too many things, honestly. But this is where we're interested in. And you have to have an agenda. And so for us here at, not at MIT, but for me here at the studio, here's what we're thinking about. Okay, yes, we're going to focus on these three. I think the Linux Foundation, we're going to nuke that. We're not doing it. This is like as of last week. And then the stretch goal for us is, okay, do we have a national health education agency that drives healthcare in the US, at least how we learn about it? So here's some of the things we're working on. And for that, you need to dovetail into bigger picture, even policy issues. How do you start having a system engineering or system design approach to what we're doing in healthcare? Because as far as I'm concerned, having term limits here in the United States for anyone elected official and Supreme Court nominees is a no-brainer, or else we're not going to get healthcare for all like many other countries have on the planet. Yeah, and I really want my Stacey Abrams. If you're not familiar with her, she's an amazing lady in Georgia. Okay, so we have to be deliberate in committing to it. So we do here at the studio, we invest our own money. So, it's not like we make huge salaries here, but whatever profit we make, we pour right back into open source. Not so bad. We need to do better this year, which we are. We have some other projects coming up. And a lot of our client investments are also pretty good. And we have, again, we're working on more this year. So, okay, so I'll wrap this up here. This is what we did last year. We did COVID, HGraph. We worked with Linux Foundation on vaccination credentials. We came up with what are the top healthcare problems for the US quantified list, and started the Own Your Health Data Act for Massachusetts. And if you're interested in this, we have a graphic novel, which we just produced in December. And we posted this at ownyourhealthdata.com is the article on Stat News that sort of outlines what this is. And you can go there. It's an evolving project.org. It goes right to the graphic novel, into the white paper. And this is a long slog. This is probably several years of work that we need to get to when it becomes a bill. So if you're interested in this, you can go to ownyourhealthdata.com. So to wrap up, healthcare is a utility. It's a human right and way too important to be closed. And to recap the whole, my whole rant here is that health data includes way more than you think. You don't own it, and you should. You need to control this access when you own it. It gives you this health autonomy by data ownership in law, and you can't solve it, the healthcare crisis, until you ask others to participate and patients to participate. And finally, having this data can save your damn life. I have stolen from all these people, and it's a long list, probably 3 times as long as that, but I want to give them credit. And if you have any more questions, you can read some things on opensourcehealthcare.org or email me at johan@mit.edu. Thank you.